This episode was produced and mixed by Mylan Tatusis, with additional production support by Dara Lucero and Peyton Jackson. If you like what we do, please like, subscribe, and share. You can find us on Facebook and Instagram at The Radical Narrative Podcast. If you wish to contact us, our website is www.radicalnarrative.com. Welcome to another episode of Radical Narrative Podcast, Season 2, Episode 2 of our long version episodes. Today we're going to be sitting down with Dr. Lyle Williams. He has been a practicing family physician for the last 10 years in rural Saskatchewan, Unity, Saskatchewan to be specific. Dr. Williams is passionate about primary and emergency care in the rural setting and is excited to work towards addressing the challenges in the northwest area of Saskatchewan, our health region, through continuous improvement initiatives and a focus on improving the patient experience. Listen in as we talk about the life of a doctor in rural Saskatchewan, COVID-19 and what it was like bracing for the incoming global pandemic. We also talk about the importance of meeting the healthcare needs of indigenous peoples, owning up to the healthcare system's mistakes of the past, important health considerations for everybody to consider, and why he moved from South Africa to Botswana during the apartheid era. I thoroughly enjoyed recording this episode, so stay tuned and listen in. Great. Yeah, so Dr. Williams, you're my doctor. Like, let's just get that out in the open. You're actually my doctor, the guy I go to for when I have medical things and my physical checkup. I know who you are. I've been following you for a while, obviously, because you're my doctor and you're in rural Saskatchewan and you're a great doctor. You're doing great work. But if you could tell us about yourself in your own way, however you want to, that would be great.
Well, thanks, Mylan. And honestly, thanks for having me on your show. My name is Lyle Williams. I'm a family physician based out of Unity, Saskatchewan, which is probably about 2 hours west of Saskatoon and about 45 minutes to an hour southwest from North Battleford. I'm originally from South Africa, been living in Canada now. We're living here in Unity for 13 years. Married, wife, 2 kids, usual story. But other than that, rural family physician is most of my background and really where most of my passion lies.
Yeah, rural family physician. I'm really excited to have you on the podcast because part of the reason I wanted to have this episode was simply just to have a one-on-one conversation with a doctor, simply because I feel we're in a time where there's a lot of skepticism, obviously, towards just medical industry in general, but we're just in a time where a lot of people aren't being really logical with, looking at research, looking at data, looking at what's taking place. So I really want to welcome you to the show and make you feel as comfortable as possible to have a good quality conversation and just a one-on-one, down-to-earth conversation.
Yeah, no, thanks. And it's a bit of a crazy time, and we really do live in a world where information is shared backwards and forwards at a really high rate, and so people tend to, if there's any sort of vacuum in information, people tend to fill it up with whatever they can find or resource or information that's quickly available. And unfortunately, in this day and age, we're getting a lot of our information from memes and quick little sound bites, and rather than having those deeper looking, like you said, looking at the research, looking at data. So yeah, I welcome it.
Cool. Awesome. Yeah. And part of what I want to do is I want to position you and just highlight who you are, obviously as a doctor, but also as an individual. So I guess we could start off by asking, why did you choose to become a doctor? Like, why this field?
Yeah, it was something that my parents tell me that I was always interested in from a very young age. My mom always tells me that most little boys would say that they want to be like their father, but that wasn't something that I chose really. I from a very young age, I always said that I wanted to be a physician. There was a couple of events really in my life that maybe pushed me in that direction. The first one was my mother had breast cancer at the age of 10, and she was traveling backwards and forwards for chemotherapy and surgery, and that had quite an impact on me at that age in my life. And I didn't quite realize it at the time until I was quite a lot older. But I think that's what sort of made me more, sort of drove me a little bit more in that direction. The second thing was when I was about 16 years old. I used to do a lot of motocross, and I actually still have a dirt bike that I enjoy, and it still is one of my passions that I said my brother and I once a year up until this would try to find a big supercross race that we'll try to watch live, and so when I was 16 years old, I broke my leg, my femur in a motorcycle accident, and that sort of changed my life quite a bit. If you think back on almost like a butterfly effect on how your life is, that was that one event where I kind of thought, well, if I'm going to be serious about being a physician or getting accepted into medical school, then I might have to just buckle down and start working a little bit harder in high school. And at the time, it was quite a traumatic and tragic thing that happened to me because you're 16 years old, you break your leg, everybody else is able to do everything, and it was the middle of summer, and I'm sitting there with a full cast. Had to go for 3 surgeries, and but it kind of helped to put my life in focus and pushed me in that direction. And when I really think back on it, I don't know if I could do anything else. I always make the joke maybe it would have been better to be a dentist, but I don't know if I could have. I don't know if I quite could have done that either. So, yeah, those are some of the things that made me choose to become a doctor.
Yeah. So coming at it from like a real lived experience of recognizing the profession, recognizing literally the need to fix bodies, and that sickness is a thing out there, and then going out there and actually doing it. That's really cool.
Yeah, that's exactly it.
Yeah, and I guess like a side joke too is you're a real doctor. Because I always tell people I'm doing my PhD, right? So they're always like, "Oh wow, you're a doctor." I'm like, "No, I'm not a real doctor." Yeah.
Well, I actually genuinely in my personal life and I oftentimes I'll tell patients just to call me by my first name. I'm not one for titles, but yeah, that's just. But I think whatever field you're studying in, as long as you feel that you're contributing back to society, I think that's really the key to finding something that you enjoy in life.
Yeah, totally. Awesome. And then, it's really cool to hear your background story of why you wanted to become a doctor and those instances in your life where you started to recognize, hey, maybe this is a profession I want to do. But in general, like what I noticed, like coming at it from the indigenous community, people know doctors are doctors. Like they know that's what they do and that's sort of like their profession, but they don't really understand what that all entails. Like basically, like for me growing up, basically I just saw the doctor when I walked into the room, or they walked into the emergency room or into the patient room. But let's paint a picture. Like what is the routine outside of that first impression? Like what is a day in the life of what you do?
Day in the life. Yeah. So, I mean, I think that there's 4 components really that, of my work. The first one is working in the clinic. So, for the most part, most interactions with people that I see will be in my clinic. The other would be in the emergency room. So we generally, in the community that I live in, we have about a 1 in 3 to 1 in 4 call roster. So, I'd be on call at least 1 to 2 days a week, potentially a weekend as well. There's also the long-term care aspect. So, that's a part that most people don't actually really get to see, is people, our elders or folks that are no longer able to take care of themselves will be in our long-term cares. Then there's also the administrative part of it. Kind of managing your own clinic. There has to be an administrative part of it, and it's oftentimes an overlooked part that you still need to turn on the lights. You need to get somebody to wash the floors and managing that on a day-to-day basis. The other parts of being a physician that maybe we kind of overlook or maybe not focus on is like you said, the person-to-person type of thing. I think that part of it is really getting to know people, and there's a saying that used to go around that as a physician you should never treat your friends or family. Well, whilst I agree you should never treat your family, it's also really hard not to be able to treat your friends if you're in a small town community. I'm on your podcast right now, so whilst we're not, I wouldn't say that we're great friends. I'd maybe say your mom. I would definitely consider your mom as getting onto that more of a friendship boundary part of things. And just a couple of weeks ago, I ended up having to do a delivery for one of my wife's friends who, that's just the nature of she presented in our ER department in late stage of labor, and that's what you have to do. There's also, and it's the positive experience. The negative experience is really watching friends that you get to know, because most of the time, if you're accessing healthcare fairly regularly, you're not healthy. If you're somebody who's in and out of the hospital quite frequently for different treatments, I tend to get to know you a lot better, and I try to leave a piece of me behind, and so that I get to know you and you get to know me. And as time comes, there genuinely is a bit of a friendship that starts to develop, and then oftentimes those people will die, and that's sort of that's oftentimes one of the hardest parts about being a rural family physician, is getting to know people very closely and watching them go through suffering and even death.
Yeah. So there's lots of elements in being a rural physician that, you have to concentrate on. And the end of life thing, I think that's also something personal for me too, because you were my father's doctor and who ultimately did pass away. And yeah, can you speak to that a bit, that experience for you?
I'm not sure if this is information that you wanted people to know, but I treated your father prior to him dying about 5 or 6 years ago. And I still to this day can remember exactly the last things that he said to me and the look on his face. It was in the emergency department, and we had just gotten some really bad blood results. I had phoned I'd phoned him for him to be seen by one of the specialists in Saskatchewan. And at that point in time, I was sort of explaining to him what was going to happen, and was giving him paperwork that he had to, obviously take with him to Saskatchewan. And he looked up at me and he said, "Am I going to be okay?" And it was for those who don't know your father, he was somebody who could almost look deep into your soul, and it was it's always hard to then try to give reassurances where sometimes having a bit more knowledge, you're looking at the blood results in front of you and you realize what's actually going on, and trying to inform somebody, but you don't want to have somebody panic at the same time. So I've kind of gone a little bit deeper into the pros and cons of being in a small town, but it's been a good experience.
Yeah, this makes a lot of sense, and thanks for positioning it that way because, yeah, we do know each other. You were my late father's doctor, and for our listeners and our audience who's not aware, I do make reference to him once in a while, and I think some people did in previous episodes. But he did pass away of cancer. His cancer came back a second time, so you would have been treating him and checking in on him up until that happened, and even after that. Yeah. But yeah,
that's correct.
Yeah. And yeah, thanks for taking to that level because I really wanted to highlight the fact that you are a rural doctor and there is like a different type of social aspect to being a doctor out here. I recognized and I noticed, and you're really good at it. Like you're a really good doctor doing the work that needs to be done, bridging those relationships. And I think, I think it's great to hear this side of things because again, some people, especially indigenous people, they don't necessarily have a family doctor, or they just see whoever is in the emergency room. And yeah, this is a quality conversation I wanted to have.
And I would really urge that's where healthcare needs to kind of move into. With having indigenous folks, I don't recall the statistics, but you're correct. A large proportion of indigenous population accesses healthcare through the emergency room and emergency department, and you don't get you can't build trust with somebody that you're seeing in the ER. You don't have the ability then to, if somebody then gives you advice, know as into is this information that I can trust because I trust the person that is providing the information. So I completely agree. Having and I think this is something that was recognized in the Truth and Reconciliation Commission's one of their recommendations was that there's an increase in the Aboriginal workforce in Canada, and to try to look at retaining that same group of workforce members. I think that what that would really help is trying to build the trust in the healthcare system as well.
Yeah, so more of an indigenous workforce in the healthcare system on all levels definitely I think would also benefit the trust and bridge the gaps that exist in the healthcare industry, because we know that there are stories and negative stories of instances happening of racism and ultimately just fuels the mistrust. It's really cool that you're positioning and highlighting the fact that, this is something that needs to be worked on all levels. And I guess the fallout of that would be also today, we're living in a time where obviously we're in a pandemic. And unfortunately, there is mistrust. Information's not being translated the way it should be, and there's skepticism and all that. But what I really want to do in this podcast is hear your take and provide, a narrative of a doctor who's been living the pandemic in real time, because you're seeing patients, you're in the front line, you're reading the data, you've been observing this for a while now. So can you paint a picture for us of this pandemic overall in general and give us some insight from your perspective?
Sure. I think, and I maybe just take a moment to pause and think about where we are in the pandemic. I mean, we're the last. I think in this past week we here in Saskatchewan celebrated a year of the first person that presented in Saskatchewan with COVID-19, and during that time period, I think we've had just over 400 deaths. This is, as currently counting, and globally, we're sitting at over 2.5 million people that have died. So I think from a personal point of view, a year ago, there was concerns about were we going to have enough PPE? What was this going to look like? What were the expectations going to be of me as a physician in rural Canada? Where were we going to? All of these sort of initial fears were really starting to bubble, and what would that look like? Particularly also, I have my own health problems, and at the time when the early days of the pandemic, I was concerned for my own safety. What was that going to look like?
Yeah. Yeah. So there's really this personal element I think that a lot of people tend to overlook with the fact that doctors are human beings. They're individuals with families who have to work with patients and people impacted by COVID-19. And that's just the reality. And again, I think part of the aspect of not taking this into consideration is because of that social disconnect. So I really wanted to position you first and foremost as a human being and a family man and a family physician who's on the front line of this pandemic. And again, like you said, you have personal health concerns that could potentially put you at risk. And I think people tend to overlook that. And I really wanted to position you first and foremost as this human being who's doing his job to help people. And yeah, and I guess a lot of people just tend to overlook the fact that, like I said, doctors are people too, and they're at risk too.
One of the physicians that treated me when I was in university passed away from COVID, and I personally know about five physicians that have died from COVID.
Oh, wow.
And last weekend, I attended a virtual funeral for one of my best friend's mother, who died from COVID. So you start to, from a personal level, you see all of this starting to build up around you. And if we go back a year, you're starting to see images that are starting to form, that are starting to come out from China and from Italy at the time, and you start to wonder, well, what is it going to be like for us? What are the next steps? And
yeah, so just systemically looking at the incoming of COVID-19 and how to create a system to deal with that. But looking back at that time from the personal aspect, was there a fear, like a personal fear of, realizing one day that most likely there's going to be a COVID-19 patient show up and that you're going to have to interact with that person and provide them treatment?
There's a baseline sort of fear that you have, but knowing that the expectations are that if somebody shows up in the emergency department, you are still going to have to go out and treat that person,
Mm-hmm.
and then trying to ensure, do we have all the protective equipment that you need? Do you have the right training? And now it's become almost second nature for us to put on and take off all of the protective equipment that we need, and to do it in a safe manner so that we don't infect ourselves. I'm talking about, when I say us, I mean physicians and nurses. Yeah. But a year ago, this was all fairly new to us.
Yeah, and for me, we started to practice social distancing, and me and my partner stayed home with our daughter and didn't interact with anything. And I kept thinking in the back of my mind, it's out there, and there's doctors and nurses and EMTs interacting with these people on the front line. And I couldn't wrap my head around it because we only saw what we saw in the news, and I was sort of curious of how that learning curve was going on the individual level for doctors and, frontline workers. Do you remember when you first had to treat a COVID-19 patient?
The first time that I actually went in to go see a COVID positive patient, and since then I've treated many.
Yeah.
But the first time when you walk into a room and that the person that's there that is coughing and running a fever and short of breath, and they need your help and they need your treatment, or need you to assess them, and then you sort of watch yourself the next couple of days and the next week, hoping that you don't have any symptoms yourself. So those are some of the baseline fears, as well as then we've had to switch our clinic over to running a lot of appointments virtually, and part of that is if you arrive in a clinic and there's 10 people in the waiting room and one person is coughing, or one person is not feeling well, and could potentially be spreading it to somebody that's in the room that might have cancer or some other condition. So we had to try to decrease our waiting room dramatically, and the guidelines were were slow at first coming, and then they would constantly change. So you're living in a world, or we've lived in a world over the last year that's in constant flux of up and down. And are you making the right decisions for your clinic staff, your colleagues, and your patients? It was really quite the first 6 months of the pandemic were quite a tumultuous times for all physicians in practice, and as well as are you making the right decisions was always at the back of our mind. I know several physicians that picked it up from patients, partly because they weren't following the right guidelines for ensuring that they are wearing correct protective equipment. Maybe a little bit too much detail, but
I really like it. Yeah, I like it because it's like the human frontline perspective, because you are a doctor and you did have to deliver care to people who obviously had COVID-19, and you're in the same room with them. And I like to believe I wasn't in the same room as somebody who has COVID-19. Like, I never did get it, and we're taking our precautions. But in the back of my mind too, I kept thinking of my family members or my even former students who are now nurses, who are like in the front line of this pandemic and are actually interacting with somebody who has it. It baffled me, and I really wanted to paint a picture for our audience to sort of understand that no, these are humans. They're not like, they're not in on a big conspiracy that they're not like, they didn't attend a mission briefing prior to the pandemic or anything. They're literal humans responding to it.
No, and that has been sometimes the frustrating part of it, because you know that you are going out there and you are attending people, and then social media posts will come out and somebody would say something along the lines of, this is not real, or this is just another method of government control, and whatever those are, and I know a lot of nurses and physicians that have felt a lot of frustration and a lot of I know of several nurses that decided not to work at all or stopped working, and part of it is the pressures of it. It's been a different time for everybody to be alive in.
Yeah, totally. And part of this podcast too is I want to, concentrate and center on COVID-19 and have you break that down for us from a surface level to give us a better understanding of what it is and how it is. So can you explain to us what COVID-19 is ultimately? Sure.
So COVID-19 is basically a virus, and it gets its name from the corona. Is Latin for crown. So if you actually look at it underneath a microscope, it actually looks just like that, like a little crown. And those are the spikes that you might hear, and you might hear of people talking about spike proteins that have been developed. It's for the most part an airway illness that is spread by droplets. So people cough and sneeze, and if you're close enough to somebody, you will inhale it. And we believe that the virus itself attaches onto different receptors that are oftentimes in your nose, or in your upper airway, so your nose or your mouth, and that's why oftentimes people will lose their sense of smell. For the most part, the rest of the healthy people amongst us, the body then treats it like it would any other virus, and you might have a little bit of a low-grade fever, and your body then recreates the virus, and you will spread it out again. We know that infectious periods often lasts about a week to 2 weeks, that you might continue to spread this through sort of droplet infections. There are some other spreads, but that's ways that the virus can spread. But that's the main reason that spread occurs.
Yeah, and I guess that does explain the lockdown response, the isolation response, the need to wear mask response, right? How those measures are in place to limit that spread, because the majority of the population who does get it will have a low-grade fever or a sore throat, it sounds like. But there's other people out there, right? There's other people who may not have that specific type of response to COVID-19. So what about those people?
in other people, unfortunately, for whatever reason, they can they can develop what we call a cytokine storm. Now, a cytokine storm is when your body's immune system starts to release a large amount of almost what we would call immune messengers. These are cytokines that are going to the bloodstream, and they will cause widespread inflammation. That will be when people have more severe illnesses that start to cause a lot of fibrosis or scarring in their lungs, and that's where you might have heard of people then having other systemic illnesses that start from the virus, including increasing blood clots that can affect blood circulation. There are people that have presented with strokes, a large amount of heart attacks that are related with this, all because your body is from the cytokines, or you're getting a large amount of inflammation that is occurring. In those sort of situations, people might have a lot more of a severe illness. We're also starting to see the term that's being thrown around at the moment is long haulers, and those are people that are continuing to have symptoms of COVID long after the infectious part of it goes away. And some of those people were maybe even asymptomatic at the time when they had the infection. They might not have got their taste or their sense of smell back, but at the same time, a lot of people might have low back pain and chronic shortness of breath, and there are several people that after their body's long gotten rid of the virus, they might still be in a wheelchair in part of their recovery process. And so I guess I would really emphasize to a lot of your listeners, this is still a new virus. We don't know really what the long-term effect. We know some people in the short term have absolutely nothing that happens, and some people will die fairly suddenly from this. But we don't know what this is going to look like 5 years from now, because we just don't have that information and we don't have that data. Trying to, obviously, prevention is really the key to ensuring that you don't catch the virus or have any symptoms from the virus.
Yeah.
Yes.
Yeah. So prevention's key here, right? Because like you're saying, there's still unknown factors. There's still like the unknown in general that could sort of have like a surprise for us at the end of the tunnel. And I think that does alarm me mostly. Like for me personally, it is alarming to sort of just think that long haulers, for example, like that was just relatively a new thing after the pandemic as people started to sort of get it. And then those symptoms persisted. Things like that, like there's still like you said, there's so much unknown here, and information changed really fast. I mean, they're still studying it. It's still coming out. And again, it's not a black and white situation we're in here. There's a lot of factors that play out, and there's a lot of very real concerns that are legitimate that we have to be mindful of. And yeah, thanks for highlighting that, because like you said, there's still unknown factors there. And I really wanted to get that point across in this episode with you.
Yeah. I mean, if you think about the HIV virus, when we're looking back at it retrospectively now and looking back at, and if you ask somebody how is the HIV virus spread, and what are the symptoms and what would that look like? Yeah, we have the basic knowledge, but if you think back to the 1980s. That was all fairly new, and there was. I'm a bit older than what you are, so I can remember that time period, and the concerns that people had about, you don't want to shake anybody's hand because they didn't have the information and they didn't have the knowledge. But we also know that people that have HIV virus, we also know that this might be something that they have chronically. And also I don't want to cause any fears about the coronavirus. We just don't have the data. We don't know what this is going to look like 5 years or 10 years from now. We don't believe that there's going to be anything to that effect, but this is still an evolving disease.
Yeah, for sure. Yeah, that makes a lot of sense. And I like how you're putting it this way because, I mean, even if something were to go wrong, even though, I'm this is just for me in terms of me being a social scientist and measuring risk and things like that. There could be like even political fallout, economic fallout, simply because these viruses just aren't like black and white. I'm sick and I'm better. There's social ramifications to these things also.
Yeah, we could go down a whole different tangent on, on this one. I grew up in Africa, right? And the social ramifications of HIV in certain countries in Africa was, it was devastating. It still is to the country and the countries that had a high rate of infection. At some points in the 90s, certain countries had 1 in 4 sexually active adults that were HIV positive. Whilst today, if somebody is diagnosed as HIV positive, we have medications that will prolong your life. I mean, if you think about somebody like Magic Johnson, the basketball player, on the surface, he still looks fairly healthy because of modern medicine. But from a social aspect of some of those African countries are still going to be recovering from HIV for many, many years to come. Anyway, that's going down a completely different tangent.
No, it's relative, especially for me, because there is an unknown factor playing out. And for me, like in hindsight, I think what was like more concerning for me was just noticing the gray area, that this isn't a black and white, you're sick and you're better type thing, and that there's all these unknown factors playing out and coming out in real time, right? Because there was even a time where long haulers wasn't a thing, but now it's a thing. So we have to be very mindful. And for me personally, like I concentrate on prevention simply because we don't know what the future holds with this virus. So yeah, thanks for positioning that, because yeah, there is a sense of urgency around prevention, I feel, and it hasn't gone away from me personally, especially as a new father. And that's partly why for me, I've been really trying my best to avoid getting COVID-19 clearly and taking it very serious on that level. And yeah, I guess we don't want to like fear monger. So there's like options where people could mitigate risk. So what's the best ways for people simply to mitigate risk and not get COVID-19, from like taking care of their personal health to their own PPE type stuff?
I think this is sort of fairly well documented, and that's one thing that has been that a lot of data has been able to show, is that just the simple hand washing, social distancing, plays a huge role in helping to prevent the spread of COVID. If you're somebody that has a lot of comorbidities, you want to make sure that your bubble or the people that are around you are people that you trust and that you can ensure that they are sort of following the guidelines. So from a personal health perspective, making sure that if you are going to come into contact with people, that they are following the precautions, hand washing, social distancing, and if you are going to go out into public, please wear a mask. There's a lot of good evidence to show that masks work, and particularly if both people are wearing masks. So if you're coming into contact with somebody who just doesn't want to wear a mask properly or follow the correct guidelines, I can't urge you enough to give yourself that space. But I don't recommend engaging with them. Just give them space and protect yourself as much as you can.
Yeah, and at this point, these should be COVID fundamentals. Like I do believe that and feel that my audience is aware of this dynamic and they're logical and pretty smart about these things. But I want to ask a question about when the pandemic first started to present itself globally. So yeah, like for me, I remember last year when things were starting to sort of take off. I remember sitting there one morning and then looking at the news and watching the news and just seeing these side articles And I think I even made a post about it in January, like even before the initial lockdowns, where I was like, okay, this looks weird. This looks like it's borderline like a zombie movie that's starting. And I was like, I felt like I was kind of right, because it started to, the wave started to come. It's almost like we were watching this tsunami sort of start to get closer and closer and inch its way in. And then it quickly made its way around the world, as we know. But take us back to the moment when you realized COVID-19 was starting to become very measurable, and even to the point of where it was forecastable. Like, okay, we know it's going to get here. When is it going to get here?
Yeah. A good analogy about zombie apocalypse. My wife quite enjoys some of those movies. I think that my initial awareness was fairly early, actually. We started to get reports of it from some of our medical health officers that in here in Saskatchewan about an emerging illness in China. But we when I say we, talking about physicians in general, we oftentimes get these sort of reports from our medical health officers about MERS-CoV, the SARS virus, as well as different sort of illnesses that are happening throughout the world. So there wasn't, it was sort of on the background type of thing. When I think there was just a couple hundred confirmed cases in Wuhan, China. And we saw that they started to build a 1,000-bed hospital. That was when I really started to pay attention. There was still no confirmed cases outside of China, but you started to think, if the Chinese are starting to build a 1,000-bed hospital, things must be a lot worse than what we are envisioning. Then we started to hear about outbreaks in Italy, and some of the concerns that were coming out of there were fairly concerning. Started receiving then quite a lot of information from doctors in the front lines in Italy about what was starting to happen there. This would have been around February last year, and how sick people were getting fairly quickly. And that was really when they were starting to have this growing fear. I also work with two Iranian physicians, and Iran was the next area, and they started to report what they were hearing from their colleagues back in Iran. There's also several Facebook groups that you have to be a physician to belong to. Sounds kind of it's not as exciting as it sounds, but it was just a way that physicians were trying to communicate what they were finding in other areas of the world, so that the next group of physicians were aware, as well as sort of specific biological markers and tests that we would look for to try and diagnose when people were getting sick early. We've come a long way from that. I mean, as we started to learn more and more. In the early days of the pandemic, we believed that you would intubate somebody fairly early, which would intubating somebody is when you're putting a tube down their throat to try to breathe for them, and you put them on a ventilator to control their breathing. And now, as time has gone, we found that was not probably the best way to manage patients, because you don't get them off of a ventilator very easily. It takes a long time. The other things that we started to become aware of is the reproductive rate. And a reproductive rate is basically if one person gets a virus, and then how many people would they spread it onwards to, or onto. Now, typically, if you think about something like Ebola, which is quite a devastating illness, but it's a bloodborne illness, its reproductive rate is around 0.6. So one person is only going to pass it on to 0.6 of another person, so not many. So if you have anything that's less than 1, then then the disease in itself will eventually burn itself out. We were getting reports of reproductive rates of close to 8, which is just astronomical in terms of, and this would be if there's no, if you're not taking any of those personal health protections like we talked about earlier, hand washing, social distancing, wearing a mask, and at that point in time, we realized that this was quite something. What I should maybe just add at this point, and I've maybe gone off topic here a little bit, is if you follow all of those protective measures, if you isolate yourself, you're not going to spread this on to somebody else. If you know that you've come into contact with somebody and you stay at home, you're not going to spread this on to anybody else. And I think that it's fairly important to maybe raise this up because most of your audience are in that 20 to 35 group, I believe. Oftentimes that group are not the group that really gets very ill, but they could be the vector. So you have a university student who is in Saskatchewan or somewhere else. They pick it up there, and then we have Easter break coming up. You travel back to your home community and go visit your grandmother, your family, have a gathering together, and that's how it spreads. So that's how those are some of the things that we need to be aware that you could be the vector.
Yeah, and being a vector is not a good thing. You do not want to be a vector. It's not a cool superhero name at all. That basically just means you're spreading the illness out there into the world. So we want to avoid that.
Anyway, I've carried on a bit more.
No, that makes a lot of sense, and yeah, definitely on the same wavelength of being mindful of those vectors, because some people could be asymptomatic, and I think that was a hard concept for some people to wrap their heads around, and it still is. Like, I still feel like it is hard for people to wrap their head around it, because they tend to feel like it's a personal attack or that you're attacking them personally, but literally asymptomatic means you don't have any symptoms and you could potentially be sick.
Yeah, exactly. And, we see it all the time or people that might just have very mild symptoms. One of my close friends, he just had a sore throat for a day, and that was it.
Wow.
That was where all the symptoms that he had. But this is a healthy guy with no comorbidities.
Mm-hmm.
If he had come into contact with his grandfather, who's also a patient of mine, I can assure you his grandfather, who has multiple comorbidities, would have been fairly ill. So that, like you said, being mindful as to who you come into contact with, and if you have any mild symptoms, even if you think that they're mild, or even if you don't have symptoms, but you're fairly certain you came into contact with somebody who might have, tried to stay away from vulnerable population.
Yeah. And one of the big issues, I think, where there was a lot of confusion, and even I demonstrated this confusion, was that people tend to assume that underlying health conditions is the biggest concern. But you're making reference to this term, comorbidities, where, that's something a bit different, and something that when I heard you explain and talk about, I was kind of like, whoa, underlying health conditions is just like a pretty surface general term. But yeah, can you explain to our audience what a comorbidity is?
Yeah, so and I think it's a good one to sort of touch on. So when we think about comorbidities, those are additional health factors that you might have, and what some people have always said to us is, well, the only people that are dying are people with comorbidities, and I'm healthy. I don't have any illnesses. But then when you start to actually look at them, they might have obesity is a comorbidity. And so if you have a body mass index over 30, you would be at risk. If you have, people don't often think of high blood pressure. as being a comorbidity. They don't think of.
Yeah.
They don't think about. Sometimes they don't think about diabetes. Even smoking is regarded as a comorbidity. So when people say I have no comorbidities, well, if you're a smoker, you do have comorbidities, and then you are putting yourself at increased risk. Keeping that in mind is also important to protect yourself and those around you.
Yeah, that's awesome. Yeah. Well, thanks for explaining that, because that makes a lot of sense. And what's alarming to me is that when we're looking at indigenous communities, our First Nations communities, we do know there's high rates of diabetes, heart's disease. And obviously, these conditions are very serious and could compound the impact of COVID-19 if it were to spread in the community.
Well, and you're 100% correct. When we looked at and this is going back to couple months ago in Manitoba, the First Nation population there only makes up about 10% of the total population of the province. However, First Nations people made up 71% of the cases of COVID-19 in Manitoba. 50% of patients in the ICU identified themselves as being from First Nations or Métis background. There are many reasons for that. Some of them are historic, and some of them are just high rates of diabetes and high rates of smoking that we find in some of the First Nation communities in the province.
Yeah. So there's very real health concerns and issues around this pandemic, and there always has been. And our communities are vulnerable communities, and I say that as an Indigenous person from an Indigenous community here. Yeah. There's also this human element that, of course we're making mistakes, and of course there's a learning curve involved in dealing with a global pandemic. And even how intubation changed, and that they realized in hindsight, okay, that wasn't the best idea because now we have experience dealing with this. And for me, this is why I don't want to be on the front line of COVID-19 on both sides of the spectrum, simply because things are changing, and they change really quickly and over time. And unfortunately, sometimes these changes are the result of a loss of life. And yeah, is there anything positive that's sort of coming out of this timeline or out of this learning curve of having to deal with this pandemic?
Yeah, for sure. And the one positive that I've seen throughout this time period has been how different scientists from across the world have shared their information and their knowledge, and even being able to identify, if we did this and it helped signifairly. I talked previously about cytokine storms, and we fairly early on we identified that if we put people that needed oxygen on steroids, we found that there would be almost a 25% reduction in their outcomes, that they would get better, and that knowledge went quickly through the medical community around the world. And so, a year ago, we didn't have that information. We probably wouldn't have started anybody on steroids, because steroids suppresses your immune system, but at the same time it suppresses inflammation. But that information became fairly quickly, and I think by the summer of last year, that was almost the standard of care treatment, almost throughout the whole world. So the information sharing backwards and forwards, and what we know today in how to manage and treat, and developments of protocols and treatments has changed dramatically to improve the outcomes of people.
Wow. Yeah. And that took time to understand it. There was a learning curve involved in that. And now today, what's your advice? What's the key to surviving COVID if it boils down to it for you, based off of your experience?
The key to it is coming in early. If you're starting to feel short of breath, if you're feeling more than just mild symptoms, presenting early is really the key to recovering quickly.
Yeah, that's cool. I think that's the first time I heard somebody say and acknowledge that to get your butt in early if it's getting to that point. Because I am hearing stories that people are going last minute, right? Because they avoid the hospital. There's a fear there, and then they tend to go in last minute in the middle of the night.
Yeah, and I can understand that. Nobody wants to wait for long periods of time in the ER. Our fear is, well, if I present in the ER, they might have me sitting there waiting for a couple of hours.
Mm-hmm.
But you're better off waiting in the ER than to be rushed into the ER.
Mm-hmm.
If you're seen immediately in the ER, in other words, if you present and within 30 seconds they have you in and you have 10 doctors around you, you're in bad shape.
Mm-hmm.
So you don't want to be that guy.
Yeah.
Rather present early, get some of the testing and treatment done. It's better for your long-term recovery.
Yeah. It's better to wait in the ER than be rushed to the ER. That's some cool wisdom.
I agree with that statement.
Yeah. Well, you said it. I just repeated it.
Yeah. Yeah.
Yeah.
I'll share the credit with you.
Cool. It's interesting. I wanted to also talk about and just touch on the fact that there is clarity here, obviously, like with how we're starting to understand COVID-19 and the treatment options and things like that. But there's still this aspect of people say, well, it wasn't that serious to begin with, or people are just getting too extreme, and that's partly why I wanted to position you as a physician observing sort of like the COVID-19 wave make its way over here to sort of like nip that in the butt, because now there's like almost a false sense of security where people say, oh, we just have to wear masks now. Oh, now I got the vaccine. Now it's good to go. Like there's almost like a false sense of security now, even though these are cool advancements and we're more aware of things now. It's almost like people don't realize we're still in a COVID-19 pandemic.
And I think that I mean, as a social scientist, you'd probably be able to answer this one almost better than I could. But I think that it's human nature for a couple of things. One is, how do we deal with our fears? We deal with our fears by in some cases just acting all brave and bravado and oh, you're still scared of that? You're still scared of the big bad wolf? I've outgrown that a while ago.
Yeah.
That type of mentality that people will have, and I understand it. As more and more data has come up, and we're looking at if you look at overall mortality rates,
Mm-hmm.
people look at it and say, well, depending on which country you are and what sort of healthcare system you're able to engage in, between 90 to 98% chance of your survival rate is that. But so people look at that and they look at that data and they think of it as, well, that means that I'll be fine.
Mm-hmm.
The truth is, it really depends on your survival rate. Also depends on your ability to access healthcare, and that the healthcare system is not overloaded. So if we take a couple of case examples, if you look at Brazil right now, I read a statistic just the other day that just over the last couple of days, 1/4 of all deaths on that particular day happened in Brazil, and they're still having daily deaths of well over 2,000 deaths per day. And you might ask yourself, well, why is that? Well, part of it is they have a different variant that started to show itself up in Brazil. They've also had a government that
Mm-hmm.
completely denied COVID their president Bolsonaro was quite adamant of portraying that bravado type of mentality and you've got nothing to fear. This won't affect you. And when there are leaders that are making those sort of statements, particularly if it's a president of a country, the impacts of that are felt way down the road, and partly why I believe Brazil
Mm-hmm.
is in the shape that they are in today. Now we're identifying multiple new strains or variants the COVID vaccine. There's the COVID virus. We've seen in Saskatchewan just recently. We're seeing a strain from the UK, the B117 strain. We've had cases that have from the South African variant that has showed up in the one reserve in the northeastern part of our province with no connection to anybody that has traveled. Now, those variants can start to spread and can start to make people really ill very fast. And we are in a race right now between having our population vaccinated and these variants starting to take off. We're definitely not out of the woods here, and we still need everybody to be vigilant and to protect themselves.
So if I were to unpack that basically and sum it up, it basically means that we are at the point where there are vaccines, but these variants could still present problems in the future.
Yeah, that would be fair. We're in a race.
Yeah, we're in a race. So there's this opportunity to give people the vaccine to have some immunity, and ideally, the variants don't take off in the future.
Well, yes, there's that fear, but what we do know is that the vaccines that we have and the technology for the vaccines works to protect ourselves from most of the current variants that are around. And because the technology is there, if we need to tweak the vaccines in the future, then it won't take as long a process to get that protection. But we're not out of the woods yet.
So now we're talking about vaccines. We now have vaccines out there that are being rolled out all around the world. What are the vaccines available in Canada right now that people should be aware of? Just the surface level conversation around what's out there.
Yeah, so good question. At present here in Canada, we have 4 vaccines that are available and that are on the market. The two that were first available are the mRNA vaccines, and that is the Pfizer vaccine, which is the vaccine that I got, and the second one is the Moderna vaccine. We've also started to see 2 newer ones. These are what we call viral vector vaccines. The one from AstraZeneca, and the second one that's just started to show its way onto the market from Johnson & Johnson.
Yeah, so there's multiple vaccines out there available now for various reasons. We'll get into that. But at the same time, I think one of the big conversations right now is ultimately, can you still get COVID-19 if you get a vaccine? And what do we have to be aware of when it comes to masks after you get a vaccine?
So your question was, can you still get COVID-19 after the vaccine? The answer to that is most likely you can still get an infection. The question that we're still trying to figure out is how can you continue to spread it? What we do know is that when people get the vaccine, they almost always have very little symptoms after they've had the vaccine. This has been shown in studies that have been done in Israel, and as well as what we're seeing locally here. We've pretty much vaccinated all of our elderly that wanted to be vaccinated that are in long-term care, and the amount of outbreaks that we've had in long-term care or people that have died from COVID that live in one of our long-term cares has significantly decreased from where we were in January. So that just tells us that the vaccines work. You might still contract the virus, but your body's immune system will fight it off fairly quickly. Will we still need to distance and wear masks? Now, that's kind of a little bit of where the information is not quite clear at this as we are right now. So in the United States, the CDC, the Center for Disease Control, had come up with new recommendations that if you've been fully vaccinated, you don't necessarily need to wear a mask if you are out in public. I still think that's maybe a little bit premature. but that's just on the current data that I have right now. So I still wear a mask when I'm in public, even though I've had my two doses, and I think it still is wise to do so, just because I personally come into contact with people that have comorbidities, and I would not want to be a vector to spread them at all.
Yeah, because it sounds like the vaccine would give somebody, their immune system the ability to fight it to the point of where they're not even aware they may have it. So again, that vector conversation and that asymptomatic conversation is really important to take into consideration, and how it's important to continue to wear a mask. So I have a question for you, just as an individual doctor who's been observing the pandemic now and has been in the front line of it. Like for me, if I was in an administrative position, what should I be looking at, and how should I be basing my decisions off of, just from a leadership perspective in general?
When it comes to it in the long run, we need to make sure that when we're making those decisions, that it's being driven by data, by hospital capacity, by the availability of the vaccines, and hopefully not being driven by just the pure politics of it all.
Yeah. And then I know we had a conversation before, we wanted to touch on that, there was a conspiracy theory going around that there are certain types of vaccines reserved for certain types of population or even ethnic minorities out there.
Yeah. And I understand that there will always be, and I remember, fairly early on, when some of the vaccines became available, I know that I believe it is one of the chiefs in Quebec, made the statement that they were receiving the Moderna vaccine at the time. He'd made the statement, well, now our community is the experimental rats of this experimental vaccine. I think there's deeper roots to those sort of concerns of, for vaccine hesitancy, and that's just comes down to mistrust of the healthcare system in general. That and I think rightly the medical community has to own some of those mistakes that have happened in the past. A lot of the decisions, in my opinion, that are made more made on it from a logistic point of view. So the reason why one area might get one specific vaccine has got to do with how easy you can transport it more than anything else. You've got the Pfizer vaccine has got very specific criteria for storage. It has to be stored at minus 70 degrees centigrade, whereas the Moderna one only has to be stored at minus 20 degrees centigrade. That's just a regular Saskatchewan winter. The two newer vaccines, really, you could store them in a regular fridge that you have. So in the long run, some of the newer vaccines might make more sense to try to get the vaccines moving out fairly quickly for all of our communities, just because of not needing that same sort of cold chain that needs to you ensure that it's not broken. I also think that there's maybe a bit of an opportunity for some of the newer vaccines, because if you're in an area where you don't trust the medical system very well, and you have somebody locally that you trust and has gone for the training, and they're able to give the vaccine, you're going to get more uptake of the vaccine. If you, Mylan Tutusas, went and had some of the training to give the vaccine, and you were able to go to wherever, and people know you and trusted you, you're probably going to get a lot better uptake than if I showed up there and said, "Hey, you should take this; it's safe for you." So I think some of those might be factors that do need to be looked at.
Yeah.
In the long run.
Yeah, for sure. I agree 100%. And I feel like the critique of basically the pandemic in general is sort of, the train has left the station. We're on this train together. And, a lot of the stuff sort of coming from recognizing the fact that we didn't have much autonomy in deciding how the train's going to operate or where it's going to go. But ultimately, I recognize myself as a passenger on the pandemic train, and we're on it till it stops, until it's over. So we just kind of got to go with the flow with this stuff right now, I feel.
And unfortunately, yeah, the only way to slow down the train is really through the vaccine, and taking some of those, protecting yourself from a personal health perspective. Yeah.
Yeah, and yeah, that was our COVID-19 conversation. Thanks for answering those, because I feel like just hearing and positioning who you are and things like that, and you being obviously, my doctor, and getting to have these conversations paints a really more accessible picture than, seeing the really dry Scott Moe briefings, or just seeing the poster on the wall that sort of just explains surface level stuff. And I'm really hoping our listeners take a lot away from this. But I also wanted to position who you are, because you also have a unique background. You were born in South Africa. It's like Africa in general is someplace I would love to visit. Obviously, the perception we have of that part of the world historically is through like Nelson Mandela, the apartheid era, and things like that. But if you want to like position yourself just in terms of your upbringing, where you were born, where you moved to in that part of the world, that would be really interesting for us to hear.
Sure. So I was born in South Africa. I was born in the 70s, in a very different time in South Africa. So my parents fairly early on made the decision that we were going to move to Botswana. So for those of you that might have to go and kind of look on the map, Botswana is just north of South Africa, and in the 1970s, we moved there. I think my parents moved there when I was about 3 months old. Botswana was really this island in between white minority controlled governments. So you had South Africa to the south. To the west of that, you had Southwest Africa. It's now called Namibia. And to the north of it, and to the east was Zimbabwe and Zambia, or at that time it was still called Rhodesia.
Wow. So you grew up in Botswana, and you were around basically these very problematic states at the time that were practicing very real, aggressive, racist, and violent policies and oppression. And like Rhodesia, like to hear you say Rhodesia, like what comes to mind for me is the Rhodesian camo. Like, you could still order clothing that has the Rhodesian bush pattern, and in jiu-jitsu, like it's a common pattern that you could get in a rash guard, and the people who only wear that are ultimately like white supremacists. So like the history of Rhodesia is a really problematic one too. So I think that kind of just speaks to the area you were growing up in. But at the same time, you were in Botswana. So for our listeners who aren't aware of Botswana, what's the unique colonial history there or in that area?
And for those of you that aren't aware of Botswana's origin, Botswana was really, if you look back in history, the first president of Botswana was, his name was Sir Seretse Khama, and he was the chief for one of the larger tribes in Botswana, and he married a white woman from England, and at the time caused quite a large amount of controversy. So it was, we could have a whole nother podcast just on that one alone. But there's a book and there's movies that are written about it. So the book is called Marriage of Inconvenience. For those of you that are interested in that history. But basically, at that time, Botswana was almost like a refuge for people that were trying to get away from apartheid governments. You can imagine if you were from an interracial marriage, and you still wanted to keep ties to your family, but you knew you couldn't live in South Africa because it was illegal. You would move to Botswana to be there, and it's quite an interesting part. And in sort of growing up in that environment, I had friends who their parents were from a mixed. I think his dad was East Indian and his mom was white. And when they would travel to South Africa to go visit the family, his sister looked more white and he looked more East Indian. So he would travel with his dad, and his mom would travel, and his sister would travel with his mom, and they would travel in two separate cars. Wow. Because it was illegal for that type of thing to happen. I mean, it was just a crazy time to even be in the country there. But growing up in Botswana was it was quite an awesome experience at the time. If you look at corruption indexes and that type of thing. Botswana has always been rated as the least corrupt country in Africa, and one of the most stable countries from a political point of view, more than anything in other countries. What was sort of interesting for me was growing up in this non-racial environment, where black and white sort of got along and all together, and then starting university. So when I went to university, this was quite a few years after apartheid had ended in South Africa. There was still some semblance of racism, strong semblance of racism still in South Africa. And I remember showing up to my first university lecture, and you in one corner were all the white guys, and one corner was all the black guys, and the other corner was all the East Indian guys. And for me, it was the first type of like, wow, we really are doing this. Hey, we were a fairly small group, and you could argue medical students are all fairly progressive as well. So that didn't last very long as everybody got to know each other. But it was, that first type
Wow.
of thing is that sort of everybody's a bit more suspicious of themselves.
Wow. Yeah. And you're from that part of the world, which is just like unique for me, because I love to hear about other places and where people come from. But specifically Botswana too, it does have like a kind of like a ironic colonial history, a bit different than how my people here would understand colonialism.
Botswana had quite a different colonialism experience. In brief, I can kind of go over it. So Botswana was at risk of being overrun by the white Afrikaans people in South Africa. They were concerned that they would overrun the country and take over the resources or annex the land or whatever would happen. This was a time when there was numerous wars and that type of thing. Three of the most prominent chiefs in Botswana at the time actually got on a boat, traveled all the way to England, and went to go ask for a meeting with the Queen. And when they met with the Queen, they requested that Botswana, or at that point it was called Bechuanaland, become a protectorate of the British Empire, which is a bit of a different concept to think of in from a Canadian perspective.
Yeah, because these three chiefs actually went on the boat and went the other way and said, hey, come in, let it make us a protectorate and a part of like the British Crown in that way. But there's very specific reasons for this type of history to unfold the way it did.
At the time, Botswana was probably one of the poorest countries in the world, with very little going for it, which probably worked in its favor. When independence came in 1969, soon after independence, they discovered diamonds, and so the country went from one of the poorest African countries to now one of the stablest and wealthiest African countries. So different experience and different time.
Yeah, different experience, different time. It's really interesting. I love the global view. Like I love to give our audience, the global view of these things. And of course, my audience knows geopolitics matter because we highlight that in previous episodes. And there's social contexts that are nuanced. So yeah, it's really interesting to hear that.
It would be. It's quite interesting to think about as well as that some of the apartheid practices and was modeled on the Canadian system, is what I've been told. In South Africa, they developed homelands, which were supposed to be modeled similarly onto some of the First Nation reserves. So, you think of it as one of the most racist governments that have ever been. Really modeled some of their practices on Canada.
Yeah. Based off the Indian Act, specifically the Indian Act of 1876, which basically oppressed my people here on the prairie. It's interesting how that document and that whole policy was looked to as something that was great and to be applied to other countries and settler states. It just baffles my mind.
Yeah, I mean, it was a way in South Africa. What they basically tried to do was, how do you strip Black people of all of their rights? and they made the decision at the time of setting up these separate homelands, and what they did there is you no longer were part of South Africa, you were from that homeland, and it was just another level of control.
It's interesting though. It makes a lot of sense because there's also like, I don't know if you're aware of this, but there's also I guess like a weird colonial link between Palmaker, our community, and South Africa, because on May 2nd, 1885, we were actually attacked by the Canadian Army and the Northwest Mounted Police, and ultimately like, British Commonwealth, basically the British, and they were led by Colonel Otter.
Yes, I am aware of that.
Yeah. And we ultimately did beat him. We do a memorial run every May 2nd, every spring.
Yeah.
But yeah.
He was quite a just a brutal kind of guy. Anyway.
Well, the British identified him as like the best infantry battalion type guy, right? So that, I guess that speaks to the type of character he was for the British to admire what he did. So.
Yeah. There's a lot of links between Canada and South Africa. A lot of Canadians fought in South Africa when they had the Boer War. So there's a monument in Toronto I was there, and I was just walking around Toronto and came across this monument of soldiers that fought and died, and Canadian soldiers that fought and died in South Africa. The history of South Africa and Africa in general is just so complex and so convoluted, and it's just quite something else. I mean, I recently did a 23andMe analysis, and when I got my genetic information back, it was like a shotgun of the whole world. It claims that I've got 1.5% First Nation blood as well. I don't know how that came into be, but apparently that's how I'm made as well.
Yeah, interesting. Yeah, I like how you described it as like the shotgun. What was it? The shotgun blast of the world.
Yeah, pretty much. Well, South Africa was, because it was, there wasn't a Suez Canal, right? Mm-hmm. So if you wanted to move boats around, you had to go. If you're going to go from the East India, the Dutch East Indies, or Indonesia, where all the spices were, to Europe, you had to stop off in Cape Town, really, mm-hmm. for refueling and, getting supplies and that type of thing. And I guess my ancestors were pretty busy.
Yeah, human interactions taking place for sure. Yeah, that's a lot of cool information and positionality. I really like it because we get to see the picture of who you are, where you come from. You're not just the random doctor that's walking into the emergency room to see somebody. You have a history, you have a family history, and interestingly enough, you are also tied to like a history of colonialism in the same way a lot of our people are too. There's history here.
Well, my part of the reason my parents actually moved or left South Africa was at one point the place where my dad grew up. His home town, it was almost like an acreage is the way I went to go see it, but it was just it was randomly assigned that was going to become white owned. Wow. Land, and because my dad was from a mixed race background, it was just decided that land is no longer theirs, and they had to vacate the area, and it was just bulldozed, and there's nothing that's growing there. They didn't redo it or anything. It was just sort of a way for population control, and they just tore down where he lived, and they would compensate you on what they determined was fair compensation, which obviously wasn't. Or if you really ever want to go down a rabbit hole, look up District 6 in Cape Town. They took an area basically which was a melting pot for people. It had people from all ethnicities living in that area, and they basically, to control the population, because you can't have that if you're in an apartheid government. You take some and you say, okay, well, we're tearing this part apart, and you can live there, and just tore apart the whole neighborhood, community, and how people were living.
Yeah, definitely. And then I think like even that mainstream movie that came out, District 9, sort of has like a political undertone around like some of the history that did take place in South Africa.
Yeah, I wasn't sure if you would get that, but yeah, you're completely right. That's where the whole there's a whole deeper tone into it, and that movie has got layer upon layer into it. The deeper you kind of look at that movie, I thought it was really well done. The main character in that movie, Vickers, it's almost like a rebirthing of him as he starts to become aware of some of the injustices that they've done to the aliens. It was a very well done, good way to, from a sci-fi point of view, to go over some of the political challenges in South Africa.
Yeah, I think they're also planning a District 10 movie, if I remember correctly. I'll have to double check. Don't quote me on it, but I think there was a sequel plan for it. Yeah.
I know that they talked about it for a while, but I mean that movie is like almost 10 years old now, so I don't know if they are, but I don't know.
Yeah.
Who knows?
Yeah, I'll have to double check, and if there is one, I'll leave it in. If it's not, then I'll take that part out.
Sure.
Yeah. But yeah, so yeah, you have a lot of like, obviously, personal lived experience of coming from that part of the world and even observing racism and just experiencing it in terms of how it systemically took place historically in your family. And we face the racism problem in North America. I mean, as a lot of people know, our listeners know, obviously, and much of it is tied to historical colonialism that has played out. So much of it is just like lingering impacts of colonization and things like that. But it also obviously exists in rural Saskatchewan, as many people know, and it's kind of a disappointment because when I go out to like Vancouver or Toronto, and when they ask if it is what it is, like if the portrayals they see in the news is what it's like, and I kind of have to have those conversations with them. And we just did an episode on white supremacy in Saskatchewan a few episodes back, but at the same time, with the awarenesses you have as a doctor and your experience, how do you as a doctor address racism in rural Saskatchewan? And more importantly, like, what do you feel needs to happen to maintain a quality health care system for Indigenous people?
It's a really good question. And, it's one that has to start from a point of trust. And I think that the medical field needs to own some of the mistakes that it has made in the past, and there's a history of bad decisions that were made from medical field in terms of there were cases of experimentations in the residential schools. I became aware of in I think it was in Manitoba, in some of the Cree communities in the 1940s. They would do nutrition experiments. There was also cases in the residential schools that the elders were forced and given vaccines and forced to undergo medical experiments that they didn't consent to. There was, I mean, if you go back in the history of Canada, or this area, there's going from the smallpox epidemic that happened hundreds of years ago. There's been many bad decisions that has led to, and with it at times obvious racial connotations to it, or racially motivated, that has led to places of mistrust. And if I was on a residential school, and if I had been forced into if somebody held me down without explaining to me why I'm getting a vaccine or why I'm getting a needle, I can assure you I would probably have a mistrust for many years ago. And most of in some cases those elders are still alive. they remembered. How can we address that? I don't know. It's obviously it's a complex issue, and I think throughout history there have been times when people have come and said this is what we should do to try and correct the system. If it's not something that all parties agree, then it's probably going to be a bad idea. So I think from my part, what I try to do, I think that's where your question was one, try to educate myself first of all, about what are the concerns from people with a different background to me, whether they're First Nation or Asian or anything that or even from Ukraine, and make sure that I'm not part of the problem, but rather part of the solution. And then if there are ideas, I think we have to be open to ideas that come up from say a First Nation elder that says this is some way that we can address these problems that have happened in the past. Then certainly try to adopt them as best as we can. I know that the Truth and Reconciliation Commission came up with certain calls for action, and I don't know if that goes far enough. I don't know if it's a right starting place, but it's better than nothing. But what I do know is that decisions that occurred in the past have resulted in infant mortality in First Nation community that is, at times up to 4 times greater than non-Indigenous communities. That we have rates of diabetes and alcoholism and drug use in First Nation communities that are higher than non-Indigenous communities, and suicide rates amongst First Nation communities that's twice that of the regular of the total Canadian population, and I believe that in Inuit communities it's 6 to 11 times higher than the general population. So I think where do we start? I mean, it starts with you and me. You get to know me and realize that I'm, as your physician, I am a person who will, and I commit to try to do better, and then it goes both ways. I think that's sort of, it has to be at a grassroots level, in my opinion. So I guess I would urge your listeners to get to know your family physician, and hopefully they'll get to know you better as well.
Yeah, well, one thing I'm really glad is that you're out here doing the work you're doing with the perspective you have. Yeah, because even like for me growing up, I was always like nervous around doctors. And I remember when I first moved home from college, my mom said, "Go see Dr. Williams. He's a great doctor." And then I was expecting like my classic image of a doctor was like an older guy, right? Like a older male, white hair and kind of senile. So I was kind of expecting like the usual older, like, white settler doctor. Then you walked in the room and you're not there yet. You're like, I was like, he's probably only a few years older than me, I was thinking. But yeah, it was really cool to like get to know you on that level and have you as my family physician. And now you're on the podcast.
No, yeah, well, and I mean, well, thanks. And I feel like I'm getting senile at sometimes myself. But, I mean, I do, I would say that I did notice like the first time I got to meet you, and I can actually kind of vaguely remember it, but as a sign of respect, you didn't engage eye contact. By educating myself, first of all, I was able to identify, this is not a sign of disrespect that some physicians would look at, because I know that I have heard other physicians say, well, why won't they just look me in the eye? So first of all, thank you for the very kind words that you said, and I think I appreciate it, and I'll continue to try to live up to those expectations.
Yeah, and it's really interesting to hear how you had this social observation of, Indigenous people in this area not making eye contact, and even how, other doctors recognize that as, a social behavior that's unique to us. And part of that is rooted in traditional kinship, respecting traditional kinship and respecting people that are respecting you, so to speak. And, I did have a lot of respect for you as a young doctor. And at that time, I do remember my father and mother speaking really highly of you. And so there was definitely a respect there for you when you entered the room. And I remember that day too. And it's really cool to have this dynamic with you, and it's great to know that you're out there doing the work you're doing with with where you're at in terms of your own awareness and historical experience and understanding. And then for my guests who aren't aware, like there's definitely a spoiler alert. My older cousin, my sister, Dr. Janet Tatusa, she is a doctor. So she is a doctor. I've been trying to get her on the podcast, but I mean, she's behind the scenes and does a lot of work in the back of the house stuff. But she also has her own practice and all that. And she always said something that always stood out to me one time when we were having dinner, and she said, about like being a doctor in the medical industry. And she said something like, we just simply need to deliver quality care. That is all we need to do. Doesn't matter who walks into the door, or where they walk in. We simply need to do our jobs and give quality care. Something along them lines. And that always stuck out with me. So that's like something that I always looked for in a doctor, was somebody who was just, getting the job done in a meaningful, heartfelt way, and you fit the bill for that. So that's something that I always like recognized in you.
Well, thanks. Yeah, and I would just say that those words that Janet said is very true and should be a mantra that all physicians should live by. I would also add that I think that Janet is far more than just a doctor. I've gotten to know her fairly well. She's probably arguably one of the most influential doctors in Saskatchewan at the moment. Doing work, leading education, and she's one of the Saskatchewan Health Authority board members. So yeah, she's amazing in many ways.
Yeah, and completely off the radar, under the radar, she's doing what she's doing, and it's really cool to see and observe her experiences too. I really look up to her also.
Which is usually a sign of somebody who's a good leader, is that you want somebody who just quietly influences things without making too much noise about it.
Yeah, I agree entirely. I agree entirely. I want to ask one last question just for our audience and obviously for me personally. But so I'm 34 years old. I'm mindful of my health in general and do my best to stay healthy. How do we strive to be healthy? Like, what's your recommendations and tips and tricks and things we should look out for or be aware of as Indigenous people?
Yeah, it's a good question. I think that in general, when we're looking at our own personal health, the first thing is, don't take your health for granted. When we're looking at indigenous communities, diabetes in our indigenous populations is rampant, and part of that has got to do with the diet that we find. We find cheap food is not always good food. We're unfortunately, we're too often eating foods that are high in saturated fats and carbohydrates and processed carbohydrates, instead of eating foods that are really good for us and healthy. And even sometimes if you think about what the diet would have been like 200 or 300 years ago in Saskatchewan, First Nation communities would have been hunter-gatherers and eating more food that they would have grown or food that they would have got from picking berries and that type of thing. Rather than getting food that might be coming directly from McDonald's. They also, if we thinking about smoking and alcohol use in our communities, I appreciate that tobacco has a sacred history amongst First Nation communities, but the use of tobacco right now is contributing to heart disease and emphysema that we're seeing in our communities, as well as alcohol. It's alcoholism seems to be a much higher prevalence in the First Nation communities than we're finding in the general population, and I can understand why That might be in certain cases. That might be people are using it to address depression or injustices that they might have experienced when they were in a residential. So all of those are sort of reasons that I would urge you to be aware of, and exercise regularly, drink plenty of water, and avoid processed foods is the best way that you don't get to know me better in the clinic.
Yeah. And I really want to develop some episodes around what you're offering up here as advice, because there are lots of social considerations and historical considerations around diet in our communities and how our traditional diet has been impacted. And I think this episode will serve as the base for those episodes that are coming up. But yeah, in general, I really like this episode. And there's three things that stand out that I wanted to highlight. One was when you asked me if I smoked, I said, no, I don't smoke other than traditional use. And then you had this metric system where you said, is it less than a cigarette a week? And I was like, probably is. And you're like the first doctor that put it in that perspective to me. So I was like, this guy is definitely aware of our traditional use of tobacco.
And by all means, I would encourage everybody to be aware as to whatever you're putting into your system. Think of yourself as a sports car or something along those lines. You just bought yourself a $5 million Bugatti or some fancy car here. They give you strict guidelines of how to take care of this car so that you can get the best use out of this car. And so what are you going to do? You're going to make sure that when your car needs to come in for a service, you take it in for a service. If you need to put in, some sort of synthetic oil, you're going to do that. You're going to make sure that if you need only to put in premium gas, you're only going to put in premium gas. We don't do the same about our bodies. If we made the same analogy, for how you would take care of something that you really prized, would you do the same to your body? And that's the best message I can give across.
Yeah, it's really cool you're saying this too, because you're giving us ideas for future podcast episodes on things we want to concentrate on.
Maybe you should have a whole bunch of doctors. I can get Janet, and we can get maybe 5 doctors together, and we can do a health one.
Yeah, that'd be cool to do it after the pandemic in a panel form. In person in a panel form. Yeah. Yeah, and then the other joke too was when I last saw you, you jokingly said, "I hope not to see you again," and I thought that was funny too, because it's true, right? You don't want to have to see your doctor too often.
I'll oftentimes say that to people, because it usually bodes well if I don't see you too often. That means that you're doing better, and I really do hope that I don't get to know you until you're older. Then we're gonna have to do a bit more checkups.
Yeah, for sure. Cool. Well, thanks for your time, Dr. Williams. I really appreciate everything you said and shared with us today. And everything sounds great.
Yeah. No, thanks a lot. I appreciate it.
No, we appreciate it. Thanks for your time, and I hope not to see you soon, as you always like to say.
All right. Take care, Mylon.
Okay.
Bye.
Bye-bye.